Bismillahirrahmanirrahim. Rabbi zidni ilma. Quote of the day. With the new day comes new strength and new thoughts. Assalamu alaikum everyone. My name is Dr. Sadia Rafiq and under the supervision of Professor Dr. Sara Afzal. Today my topic of presentation is measures of mortality. Learning outlines include the introduction to mortality, measurements in epidemiology, tools of measurements, measures of mortality, standardization, recent updates, and multiple choice questions. At the end of this presentations, participants would be able to describe mortality, its significance, measures of mortality, and standardization. Measurements in epidemiology includes the measurements of morbidity, mortality, disability, natality, presence, absence, or distribution of disease, medical needs, healthcare facilities, presence, absence, or distribution of environmental factors suspected of causing diseases, and last, measurements of demographic variables. The tools of measurements are rate, ratio, and proportions. Rate is a measure of occurrence of some particular event in a population during a given time period. It comprises of numerator, denominator, time specification, and multiplier. There are different types of this, which are crude rates, which include the crude birth rate, death rate, then the specific rates, and standardized rates. Ratio is a relation of size between two random quantities. The numerator is not a component of denominator. For example, sex ratio, doctor population ratio, child women ratio. Crude and specific rates. Crude rates calculated for the entire population, whereas the specific rates calculated for specific subpopulation, which includes the age specific rates, the race specific rates, or gender specific rates. Crude death rate is a number of deaths during the year divided by mid-year population multiplied by a multiplier. Decrease in CDR provides a good tool for assessing the overall health improvement in the population. They lack the comparability for communities on national or international level because they differ by age, sex, or race. If we compare a death rate in two populations by age, you can see it's the population A, it's population B. The age specification is less than 15, 15 to 44, and so on. The population, number of population is this. At this population, the annual age specific rate is this. Annual number of death is this. And if we calculate the annual number of days is 45, and that all ages population is 5,000. If we divide by this, it is the crude death rate per 1,000 is 9. And the population, same, if we divide the annual number of death rates with the total population, it is 5.8. So there is no difference in two populations in risk of death. Population A has a crude rate for large aged population. If you see in population A, more than 45 are 1,500, whereas in population more than 4,500 are 500. So there's a difference now in the crude CDR in both. So CDR may not always reflect risk of death in a comparative study. Measures of mortality. It includes the cause specific and age specific, then the case fatality rate, proportionate mortality rate, and standardized mortality rates. Moving towards mortality rate. Annual mortality rate is equal to total number of deaths from all causes in 1 year, divided by number of persons in the population at mid-year, multiplied by 1,000. Mortality rates, age specific. So age specific annual mortality rate is total number of deaths from all causes in 1 year per age group. So in this, we divided the different age groups, divided by number of children in a population and mid-year per age group, multiplied by multiplier. Then the mortality rate, disease specific. Previous one was age specific, not disease specific. Annual mortality rate for lung cancer means total number of deaths for lung cancer in 1 year divided by number of persons in the population at mid-year multiplied by 1,000. So if we talk about total and age specific mortality rates, which is deaths per 1,000. So we have different age groups. This is the population. These are the death rate, but deaths by age, each age group. This is the death rate. We divided the deaths over the population, we got the rate. So you can see more than 75,000. This is the population. Death rate is so high, 73.1, but the aggregate total is 9.9. Now, infant mortality rate, it is the number of deaths in a year of live born infants less than 1 year of age divided by number of live births in the same year multiplied by multiplier. Case fatality rate, it is the total number of individuals dying during a specified period of time after disease onset divided by number of individuals with the disease of interest multiplied by 100. So if we see the COVID-19 fatality rate by age, you can see these are the different age groups, 10 to 19 years to 80 plus. And the fatality rate is 0.2% in this age group, and 80 plus, it is 14.8. So beware of fatality rates. When you hear about the risk of dying from corona, you probably think you hear this, but it is often this, which is not the same thing. Case fatality rate is the deaths over cases, and it is not same infection fatality rate, which is death divided by infected. These two rates are different because the known cases does not include all infected. Again, you can see in case fatality rate, 1 fatality in 4 cases, whereas the infection fatality rate in 1 fatality in 7 infections. So both are different things. Then comes a proportionate mortality of a disease. The total number of deaths for a disease in a given year divided by total number of deaths in the population during that year multiplied by 100. Maternal mortality rate, the number of maternal deaths in a given period per population of women who are of reproductive age. So numerator is maternal deaths and denominator is women of reproductive age. You can imagine this picture. Just to remember, it's the maternal death out of women of reproductive age. It is MMR, maternal mortality rate. And when we talk about ratio, it is the number of maternal deaths per live births. So it is a basic difference between rate and ratio, in which numerator is maternal deaths and denominator is live births. Maternal deaths and live births is ratio. Moving towards standardization. Standardized rate is equal to weighted average of category specific rates. Standardized rates can also be called adjusted rates. For example, age adjusted, gender adjusted, or race adjusted. Adjusted rates are created through standardization. So standardization is a process by which you drive a summary figure to compare health outcomes of groups. The process can be used for mortality, natality, or morbidity data. Direct adjustment. Rates of population to be compared apply to the standard population. The question is, what would be the number of events in standard population if events were happening at the category specific rates in each population? So example is age adjustment. Number A is the direct method, requires age specific rates in the sample population, which includes the age of each case and the population at risk for each age group in the sample. And second is age structure, which is a percentage of cases in each group of a standard population, which I just show you. It is a calculation of expected number of deaths by direct method, which is the same age specific rate. So these are the different age groups. Then standard population A and B are combined. If you see in population A specific rate is this, expected dates are this, and in population B, it is same, identical. Same age specific dates and expected dates. So all ages are 10,000, expected is same. So while crude death rates were different, adjusted rates are same for two populations. The previous slide, which I showed you, the crude death rate was different in both populations, because in population A, the number more aged group was higher. So in that, the crude death rate was higher. So, but in these, you can see the crude dates was different, but adjusted dates are same for the two populations. Risk of death is identical in population and B. Age adjustment has removed distortion in risk of death from crude death rate. So in which in the calculation is by different age specific rates. In this previous one with the same age specific rates and now different age specific rates. Now you can say again the age groups, standard population is this, age specific death rate is this, and expected rate is this. But in population B, the age specific death rate is different from it, and the expected rates are also different. So in total, it is 74 and it is 92. So adjusted rate for population A would be 74 divided by 10,000 multiplied by 1,000 is 7.4. And for population B, it is 9.2. Different risks of two deaths in two population are preserved by age adjustment. If we go for direct age adjustment, if we directly adjust, it is in the year 95 to 2000. Population was 90,000. Number of deaths were 862 and death rate was 96 per 1 lakh. And again, in the next coming 5 years, the population was 90,000, but the number of deaths is 1130. Here it was 862. So death rate automatically increased from 96 to 126. Direct age adjustment, if we compare the age-specific death rates. So these are the different age groups, and it is the year of 95 to 2000. You can see the population of each age group, number of deaths in each age group, and the death rate. Again, in next coming 5 years, the population has changed. You can see the total population is 90,000, but 30 to 49 here were 50, here is 30. Here is for 30, here is 40, and 70 plus for 1 lakh, here is 2 lakh. So death rate per 1,000 is 350 now, and here is 406. Direct age adjustment using total of two population as standard. Now in this, again, age groups are here, standard populations are written. In this, in 96 to 2000, age-specific mortality rates are also given. And expected dates are by multiplying by age by 12, and we got it expected death rate, which was total this. And in this population, its expected death rate was 1830. So age adjusted rate, we divided 2238, which is an expected death rate, by the population of all ages. We got 24.3. And in this age group, we divide 1830 to 18,000, it was 101.7. Now moving towards the indirect adjustment. Rates of standard population apply to population to be compared. The question is, what would be the number of events if the particular population was having events at the same category specific rate as the standard population? So indirect method requires age structure, which is the percent of cases in each group of a sample population, total deaths in the sample population, and the age specific rate for the standard population. We see in the next slide. Indirect standardization is that instead of standard population structure, you utilize a standard rate to adjust your sample. Indirect standardization does not require that you know the stratum specific rates of your cases. The summary measures is the SMR, or standardized mortality or morbidity ratio, which is SMR is equal to observed divided by expected multiplied by 1000. And SMR of 100 means no difference between the number of outcomes in the sample population and that which would be expected in the standard population. So if we see indirect standardization, calculation of the SMR for male farmers of all causes of death. So here again, we have the age groups, number of factory workers and managers, this one, then the standard death rate per 10 lakh, all causes of death are written over here. And the expected number of death, 3 comes from 1 multiplied by 2, it is this. So total expected death rate per year was 2083 and observed death rate was 1464. So SMR is computed by the observed death rate, which was 1464 divided by 2083 multiplied by prior, and it is 70.3%. So if again in the next example, SMR for tuberculosis for minor ages 20 to 59 years, again age group, estimated population of minors, then the death rate per 1 lakh. Expected deaths is calculated by multiplied by 1 multiplied by 2. We have the expected deaths and the observed deaths. Okay, so by applying the formula again, if we want to see in the 20 to 59 years old, 20 to 59 years old, 436 were the observed rate and total is expected was 181, multiply 241. What 241 means? The SMR 100 means It's normal in sample in the standard population, but 241 is more than 100. So it means the SMR for tuberculosis for minor age is 241, but they have 141 times more chances of having tuberculosis than the standard population. Again, the direct standardization, some individuals contribute different amount of risk due to length of exposure. It is hypothetical example illustrating calculation of stratum specific SMRs. You can say the age groups and the study cohort. These are the observed deaths and these are person years. It means how many people, how many the person and what length of the time they are exposed to in the cohort studies. It is in the population, reference population per 1,000. Was the expected death rate, and this was the MR. Again, it is divided by, SMR is divided by the observed death rate, and we multiply by 100 and calculate it. So comparing mortality in different populations includes the crude age adjustment, which is direct or indirect or SMR, then the cohort analysis, then the life table analysis, which includes a median survival and life expectancy. If we compare the comparison of rates, advantages and disadvantages, if in the crude rates, actual summary rates readily calculable, but disadvantages are difficult to interpret because of difference in population structure. Specific are the control for homogeneous subgroups, provide detailed information, but cumbersome in there is many subgroups. There's no summary figure basically. Adjusted, provide a summary figure. It's very hallmark. Controls confounders and permits group comparison. It's the frictional rate, magnitude depends on population standard, hides subgroup differences. So mortality data is comprehensive, measures of community health, take trends over time by region, proportionate mortality, infant and applies to men and women, cohort analysis, standardization for comparison across population and for demography. The sources of information of death includes a death certificate, clinical records, autopsies, surveillance programs, village records, and the population could be census, through census, hospital admissions, fixed cohort, or estimates. Mortality data problems. Change in coding of ICD, deviance, change in definition of disease, underlying cause of death excludes information of immediate cause or those in between two. Denominators may not be available, and numerators alone does not give rates and calls for standardization. Sources of errors in mortality statistics are the fact are inaccurate, demographic, age, sex, race, ethnicity, marital status, occupation, the place of residence, not occurrence recorded, cause of death, very inaccurate, immediate cause and underlying condition, and changing taxonomy. Trends and mortality artifactual are the numerator, errors in diagnosis, errors in age, changes in coding, changes in classification, and in denominators, errors in counting population, errors in classifying by demographic characteristics, and differences in proportion and population at risk. So why we study mortality? Basically, eternal ultimate experience, a measure of disease severity, effectiveness of treatment, surrogate for incidence in severe fatal diseases, comparison of rates in two or more populations or one population at different times. So moving towards the recent updates. It is a WHO mortality database in which the frequently asked questions are available. And if we want to see the mortality rates of any of the measurement of any country, is available on the WHO mortality database. It was an article in which updated standardized mortality ratio evaluation of disease risk of shipyard workers exposed to low dose ionizing radiation, in which the objectives were to examine the risk of disease among industrial workers with low or fractional radiation exposure, in which 3,7,200 US-based shipyard radiation and non-radiation workers were followed for 54 years and compared with US men using standardized mortality ratio method. In this, the conclusion was a US shipyard male radiation and non-radiation workers did not show any elevated mortality risk that might be associated with radiation exposures. It was one of the articles in Annals of King Edward Medical University, an outlook of the COVID-19 infection magnitude in Pakistan and potential risk contributing to low mortality rates. In this, in Pakistan, mortality rate was low, which was 2.06 than the neighboring countries and even economically advanced country. So the data was collected from December 2009 and July 2020 One study for population age spectrum, health facilities, immunization profile, physical activities, and obesity from Pakistan and other countries. So Pakistan has 2.6% as compared to France, Italy, UK, Spain, which have the high mortality. So the small population may be due to exposure to different viral antigens, a high rate of BCG vaccination, better physical activity practices, and low obesity prevalence in Pakistani population as compared to European and North American population may contribute to lower COVID-19 related mortality rates. These are my references. And now moving towards the multiple choice question. A researcher is comparing the mortality rate of Pakistan and Afghanistan. He prefers to use direct standardization to eliminate the difference of cause of death, numerators, age distributions, denominators, or deaths in epidemic. Anyone? Yes, C is the correct answer, age distributions. The crude death rate in community A was higher than crude death rate in community B, but the age adjustment mortality rate was higher in community B than in community A. This indicates that investigators made a calculation error. No inference can be made about the comparative age of the population from this data. The population of community A is on average older than that of community B. The population of community B is on average older than the community A, or health status of community B is on average better than community A. Which one is the right option? D. No. C is the correct answer. The population of A is elderly people are more. So the crude death rate of community A was higher than the CDR of the B. So C is the correct option. The population of community A is on average older than that of a community B. MCQ number 3. A medical student is assigned a task to find out the mortality rate of two cities by means of direct standardization. During his assignment, he might not need a specific death rate. A standard population is needed. Population should be comparable. Two populations are compared. Morbidity data of both populations. Yes, E is the correct answer. Morbidity data he might not need. Standardized mortality ratio permits adjustment where A-specific rates are not available or unstable because of small numbers, like in intravenous drug abusers, which may not be helpful or true for assessing SMR. A uses crude death rate as a yardstick, is calculated by observed death and expected deaths, permits adjustment for age of understudy population, can be used for disease as event of occurrence, can be used as a tool to higher payments of risky population. In this case, uses crude death rate as a yardstick because IV drug abusers don't have that much big number. They have the small number, small percentage. So crude death rate would be used as a yardstick. When studying the death rates pattern of a population, why do demographers usually analyze a specific death rate instead of crude death rate in their research? Because death rates vary considerably by age, because we cannot accurately measure deaths by age, because the Center for Disease Control and Prevention won't release annual death rates in a timely manner, so that we can standardize death rates and exclude death rates, the acts of violence, because the world's population is growing very fast.
Charlie?
No. The correct answer is because death rates vary considerably by age. That is why it is divided into different age groups. Since 2017, country X has experienced a large outbreak of monkeypox with over 500 suspected cases, over 200 confirmed cases. The observed death rate due to monkeypox is 45 and expected death rate of country is 30. Calculate the standardized mortality ratio. You might be all remembering the SMR formula is observed divided by expected multiplied by 100. So you may need some time to calculate it. So the correct option is E, which is 150. I tell you its solution. SMR formula, we put the value of 50 divided by 30, it is 150%. In the relevance with the previous, my previous MCQ, the SMR is calculated to be 150%. How will you interpret it? Mortality due to monkeypox is 50% higher than that of country. Mortality due to monkeypox is 50% lesser than that. Mortality due to monkey 100% higher than that country. Mortality due to monkeypox 150% higher than that country. Mortality due to monkeypox 150 times lesser than that of country. The correct option is A. I have told you 100 there's the same, there's no risk factor. It's the same in the sample and standard population, and 150 means 50 times higher than the 50 is more than 100. So mortality due to monkeypox is 50 times higher than that of the country. To calculate the mortality rates by direct standardization, standardized population is taken. Standard population that in which has excellent health indicators belong to a developed country, has age and sex composition known, death rate is higher than the birth rate, and adopts healthier lifestyle.
D.
C is the correct answer, has age and sex composition known. D. The rate adjusted to allow for the age distribution of the population to compare the death rate of two countries. Perinatal mortality rate, crude mortality rate, fertility rate, age standardized mortality rates, disease specific death rate.
D.
B.
B is the correct answer. Age adjusted mortality rate is taken. The crude death rate of Pakistan is 9.1 per thousand population. Flood affected population of Pakistan has observed death rate of 30,000, while the calculated expected rate is 25,000. What interpretation can be made by this data regarding the death rate of flood affected population? Flood affected area has experienced higher casualties. Huge casualty will be expected in near future. Not much casualty occurred as expected. A large casualty has been prevented due to the operation. Famine is a major contribution for causality. If you see in this, I have asked how you interpret and have given you the observed and expected data. So you have to calculate the SMR, which is observed 30 divided by 25,000 multiplied by 100, and answer comes 120. So it is 20 times higher than 100. So option A would be correct answer. Flood affected areas has experienced higher causalities, casualties. This is the key, and this is the YouTube link. Kindly like, share, and subscribe it. And thank you so much.
Thank you very much, Dr. Sadia. Very nice presentation, and especially the part that you have cleared the concept about the case fatality rate, infection fatality rate, and how the standardization is done, age specific rates. This is really wonderful, because many students, they have a lot of difficulty in understanding the concepts of standardization and how the standardization is applied on specific rates. Case fatality rate, infection fatality rate we have seen in during coronavirus infection disease 2019, that is also called COVID-19, that this disease has different infection fatality rate and different case fatality rates. And the reason is because the total number of the people who were getting the infections, they were much larger in number than those who were presented as cases at any healthcare facility, or who were being diagnosed by PCR or other screening tests during the infection period. So the case fatality rate, infection fatality rate, it is a very important concept that has been presented today. The second important thing is about the standardization, how the direct standardization method and indirect standardization methods, they are different, and how they are being applied, how the age-specific standardization is being done is really one of the key element in our basic morbidity indices. Similarly, in mortality indices, these standardizations are important in order to know how Pakistan is performing on different important indicators like maternal mortality, neonatal mortality, and infant mortality. And these rates, once they are standardized, it is much easier to compare than the non-standardized rates. The next important point is that your MCQs, they were brilliantly presented. they were very well thought of, and the scenarios were really good one. Thank you very much, everyone,
Thank you.
for joining the class today.
Thank you.
Okay. And thank you very much. Allah
Thank you.
Hafiz.
Allah Hafiz.